Right, so we will get started. So it's just after 3. Brett and Ruth are on away on vacation today. My name's Ashley, and I'll be one of the hosts. And I have Dr. Sanchea Wazaloo with me today. We're going to be co-hosting this. She graciously volunteered to help me out.
Our volunteered.
Yeah. So we just got a couple things before we get started. We're going to do our land acknowledgement. So while we meet today on a virtual platform, I would like to acknowledge the Indigenous peoples of all the lands that we are on today and take a moment to acknowledge the importance of the lands which we call home. As we gather here today, we pay our respect to the First Nations and Métis ancestors and reaffirm our relationship with one another. The purpose of these virtual rounds is to discuss pertinent topics throughout the continuum of stroke care. As a reminder, this is not a secure confidential platform, so no patient health information will be shared during this session. We'd like to emphasize that this is all about community and sharing and learning from one another. We know there are several participants here who may also have experience and expertise in stroke, so please share your tips and knowledge too by chiming in. I'll be monitoring the chat at the same time. And then after Dr. Plecash is done, then we will have a little Q&A at the end. And then I got the golden lobe. So, as usual, we have our little golden lobe, and we had one nominee. So this is to celebrate. This is Ruth's doing. So this is to celebrate, and you know, celebrate people's contributions and expertise.
So
Oh, someone's not muted.
We adjusted the leg rest and we shortened the left one, but then the right one seemed like it was okay because she was playing around with the elevator.
Someone's not muted.
Caitlin's saying that she's saying that the right one was too short.
Okay. Maybe not. Okay, so we have a nomination for Karina Porter. She's an occupational therapist at Rehab Outpatient Specialized Services, or ROSS, at City Hospital. And she is the creator of the Brain Boot Camp group and a champion for evidence-based care.
Oh, cool.
Oh, what is going on? All right. So I'll do a little bit about the stroke day at the end. There we go. Okay, so today we have Dr. Plecash. She is from Vancouver, and I'll read her bio. So she's a certified stroke neurologist, thrilled to work as both a stroke and general neurologist at Vancouver General Hospital in Vancouver. She grew up in BC and completed her adult neurology residency training locally. Ali completed a clinical stroke fellowship divided between Vancouver and Toronto, so both sides of the country, with an interest in women's stroke / cerebrovascular disease in pregnancy. She has recently opened Western Canada's very first women's cerebrovascular health clinic in Vancouver. That's so exciting. And looks forward to working collaboratively to develop and grow awareness and expertise in women's brain health care. So welcome, Ali. Very excited to have you on here today.
Thank you, guys. Sorry, I am on call. I do have a colleague covering me, but my pager may go off in the background. So just ignore that horrific sound. All right, so I will, I'll share my screen here, and then you guys are all gonna disappear. So maybe if questions pop up or if you want to get my attention, just yell at me because I won't be able to see anything. Okay. All right, and we want to go till what, 2:45, right? Or yeah. Sorry, you're 3:45.
Yeah, but
yeah. Okay. Yeah. Okay, sounds good. Okay. So yeah, thanks so much for the intro. I will try to be not too boring, but I do love talking about gender issues in stroke care. So we're going to do a little bit of that today. So kind of on the spectrum of gender, when I was prepping, to be totally honest, this was stolen slightly from a talk I gave to the BC group last year. But in thinking about gender, and when you Google stroke person, try it if you have never done that, this is what comes up. And as I might highlight for you, there are only 2 women on this first slide. One appears to be, oh, I think someone's mic isn't muted. One lady appears to be very concerned helping her husband or some man in her life with what looks to be a heart attack, not a stroke. And then somebody over here maybe looks like she's having a Bell's palsy or something, but otherwise it's a very male dominated kind of imagery on Google. So knowing that, but then also looking at what the data tells us, it's not super congruent. I think kind of classically heart disease and stroke were seen as illnesses or diseases of men, but actually stroke is the 3rd leading cause of death in women. And if we take a peek at this graph that was published in an American Heart Association publication from a couple years back now, we can see that in terms of a percentage of total deaths in women versus men, looking at those curved lines at the top, the percentage of total deaths in women is higher from stroke than it is in male. And numerically, when we look at the bars here, we can see that women outnumber men numerically in this kind of young age, like pregnancy, birth control, I suspect time. And then in the elderly, and we can see that kind of after the age of 90, women have double the number of strokes that their male counterparts will have. So knowing this, I wonder, and maybe by the end of the talk I can convince you that maybe a shift in our perception about what our illness script is for stroke makes sense. So rather than like automatically thinking of at triage or when we're taking outside phone calls or seeing people in the office about the 61-year-old man with hypertension, dyslipidemia, diabetes, smoking, who comes in with a left hemiparesis, to equally considering stroke as a possibility in the 55-year-old woman who's had prior history of preeclampsia and a pregnancy, who's now 10 years post early menopause, who comes in with a left hemiparesis. So this is just a little schematic about kind of unique times, factors, risks in a woman's lifespan that might influence the risk of stroke. And we'll kind of use that imagery and then this outline to go through some of these times in more detail today. So we'll talk a little bit about estrogen and its impact on cardiovascular health, and then we'll kind of look at a couple of cases looking at the risk of stroke related to migraine around pregnancy and with kind of hormonal contraception, and then talk a little bit about menopause and stroke risk. So what does estrogen do to our vascular system, and how does it impact health or disease? So the short-term effects of estrogen are really, really positive in that estrogen overall promotes vasodilation. It's an antioxidant. It increases nitric oxide bioavailability in vessels, allowing the vessels to vasodilate, and decreases the generation of oxygen-free radicals. What does this mean for exposure of our blood vessels to estrogen over time? Long term, these are like looser, more dilated vessels that have less free radical damage. There's going to be less development of atherosclerosis, less vascular injury because the estrogen is protective of the vascular endothelium. How about what happens on a shorter term basis? So this was actually kind of a cool study that was published following cholesterol levels over the course of a woman's menstrual cycle. These poor women who had their blood work checked like a jillion times during a single menstrual cycle, but kind of interesting to note that total cholesterol levels actually fluctuate with estrogen blood estrogen levels during the menstrual cycle, whereby kind of we see protective effects of our cholesterol, kind of increased HDL, decreased LDL, and responsive total cholesterol at times when the female body is exposed to more estrogen. And then moving away from the vascular system, looking a little bit more at the heart. What does estrogen, if anything, do to the heart? So it does impact our heart's contractility, some of the electrical functions, like how quickly repolarization happens, and how likely a heart is to develop arrhythmias like atrial fibrillation. Estrogen has an impact on insulin sensitivity and therefore the development of diabetes. And overall, leads to a reduction in blood pressure through this like more complex than I understand mediation effect through our aldosterone, kind of renin-aldosterone angiotensin system in the body. So that's kind of where our bodies are going to sit for a large majority of the female lifespan, of course, until menopause, whereby our body is exposed to estrogen, which although is more procoagulable, has a lot of protective vascular kind of benefits and reduction in blood pressure, cholesterol, blood sugars. So that's kind of what our body is used to for a large number of years. And then obviously there's a change at menopause that we'll talk about. As we're going through these years, let's talk about a couple of other disease states that are more common in women and how stroke might manifest or be related there. So we'll start off by talking about the impact of migraine on stroke risk. So, I mean, I don't need to tell this audience that migraine is one of our primary headache disorders that's believed to be a vascular problem in origin, whereby our kind of autonomic nervous system, our fight or flight system, activates our trigeminal vascular pathway, and we get this inflammatory cascade of these neuroinflammatory peptides that give us headache and cause inappropriate artery vasodilation. So how is this related at all to ischemic stroke? There's lots of different proposed mechanisms, things like seeing more or proposing that there's increased levels of endothelial dysfunction in people who have chronic migraine, that there's probably some genetic component linking these kind of vascular conditions. Potentially that chronic migraine can trigger some coagulation abnormalities and make people more prone to arterial dissections, but kind of one of the common things is the knowledge that the presence of a shunt or a PFO, a patent foramen ovale, common in the general population, about 1 in 4 people will have, but super common in migraineurs. So up to 85% of people with migraine will have a patent foramen ovale. And potentially that's kind of one of the linkages to the rate of increased ischemic stroke in the migraine population. So how does this affect women specifically? Well, migraine's not a disease just of women, but it sure does affect women more than it does men. So about 3 women to every 1 man will be affected by migraine. And, somewhere around 22 to 37% of women will be affected by migraine during their reproductive years. We can see that through like large data sets, there's an association between migraine and ischemic stroke risk, especially in women who are under the age of 45, and especially in that age group of women who also smoke and or use oral birth control. Some more recent studies are showing that migraine frequency seems to be linked to increased stroke risk. So people who have more frequent migraine are at higher risk of stroke, but we don't yet have data to show us, okay, if we use, some of our new good medication therapies and we reduce the migraine frequency, are we actually able to impact stroke risk? So I think that'll be super, super interesting stuff for us to look into kind of down the road here. And then what about migraine therapy and risk of stroke? Triptans, I think in general have kind of a bad reputation for being dangerous for people with heart disease or stroke. So let's walk through that just a little bit. Let me see, can I hide this little? Okay, perfect. So overall, for sure, there's good data to show us that triptans do increase the rates of ischemic stroke events. But overall, the numbers are quite small. If anyone is interested in like the actual primary publications, I can send these PDFs to Ashley and she can distribute them, or you can just look them up on your own, whatever's easiest. But this is quite a nice, recently published Danish case crossover study looking at almost 500,000 people with migraine using triptan and looking at the rates of ischemic events. In general, kind of what does the flavor of the data show us? The people who seem to have the higher risk of stroke were people who had other risk factors and were the older people. So people who were using triptans over the age of 60 and who had other risk factors, like maybe they had dyslipidemia or they had hypertension or things like that. So that's kind of the population that I think we really want to be careful about using these in addition to, patients who have had a prior stroke or coronary artery disease, we would choose not to use triptans. And then what about some of our newer therapies like the CGRP, treatments for migraine? Overall, data is still early, but things are actually looking pretty favorable. Overall, kind of observational, again, early data shows that there seems to be actually less stroke by number in migraine patients using CGRP therapies, but there's a signal towards increasing blood pressure with more chronic use of these treatments, and that's one of the things that we would monitor for when we have patients on these therapies. Interestingly, though, in some animal studies, when they expose animals to CGRP migraine medications and then look at, okay, how does the brain respond to ischemia if they, take, say, there's some studies in rodents where they ligate or block off the middle cerebral artery when their brain's exposed to these therapies and then look at, okay, how big of a stroke develops. And actually, we're seeing that in brains that are exposed to CGRP therapies, there's a larger territory of ischemic stroke that develops. So it's interesting, a little bit kind of contradictory in terms of what we're seeing in real life with reduction in stroke to kind of what we're seeing in these animal models, but something to keep an eye out for in the coming years. All right, so we'll move on from migraine to talk about pregnancy and its prevention, which we do for so many years of our lives, on the risk of stroke. So what do we know about birth control? So we know that birth control, particularly OCP or oral contraceptive pills, are associated with increasing procoagulant factors in the body. And the ischemic stroke risk is largely linked to the amount of estrogen formulated generally as ethylene estradiol in these compounds, and that with higher doses of estrogen in these pills, the relative risk of stroke is increased. So these the early combination pills, this was more from like around 1950s, 1960s, had quite high doses of estradiol in them and came with about a 2.75 relative risk increase in ischemic stroke. Our current combination pills, generally all of them are less than 50 of estrogen and mostly kind of in the 30 to 35 range, even some lower than that. And with these newer pills, there's another, Denmark has such wonderful registry data, so really nice to look at with really big numbers. But Again, recent publication from last year showing that in more than 2 million women exposed to exposed to birth control or not, and when they followed them over time, being on a combined oral contraceptives came with about a 2 times increased risk of stroke, which sounds like a big difference, which it is. But numbers are small, right? Like total numbers in this population are 18 strokes per 100,000 person years, with no OCP use versus 39 per 100,000 person years with OCP use in this group of Danish women. And then there's also some curious data on IUDs or intrauterine devices. Again, another kind of large cohort data from cohort study from Denmark, looking at the risk of IUDs and stroke. And this one data set with quite a large group of women, over 1.5 million women, showed that progestin-only containing IUD users, so Mirena IUDs, Kyleena IUDs, had actually a 22% reduced ischemic stroke rate compared to general non-birth control users in the population, and similar rates of hemorrhagic strokes. Obviously, this is an observational study. We can't make policy changes and things about it, but if I was going to suggest to a patient who had stroke or significant stroke risk factors and needed contraception, this is certainly what I would suggest if it was kind of okay to them to undergo an IUD placement. So this is one of the young women I follow in my practice. Just food for thought for you, and feel free to jump out with ideas if you want to. Otherwise, I'll talk through. But I follow Alyson, who's a 22-year-old preschool teacher here in Vancouver. I met her after last year in 2025. She was at the movies with her boyfriend, came out and had a clear syncopal event, got dizzy, tunnel vision, dropped to the ground. Went into hospital, and as part of her workup, I think because she had a bit of a head bump or something, they did a CT scan that shows this little kind of chronic looking cerebellar stroke. So she was referred, and I saw her in our stroke clinic for review. So some things to think about in her. So she's 22. I mean, that stroke was old when the CT was done, so definitely didn't cause the episode of collapse. An MRI done kind of later on also showed that that was not acute, that was very old. It has never caused her symptoms, so it's technically a covert stroke or a silent stroke. She goes through a bunch of stroke workup, and we find that she has a really large patent foramen ovale with right to left shunting. So what do we think about that? She has this asymptomatic stroke, but a really big PFO when she's 22. And then kind of thinking further on that, she also takes combined oral contraceptives. Is this okay for her to continue to do so with a big PFO and a covert stroke? Remembering that we only found out about the stroke because she had an unrelated medical thing happen and had her head scanned. And then as well, she has a history of migraine without aura. Knowing what we know about her now, are there any medications, treatments, agents that you would try to use in her and any that you would avoid? If anyone has thoughts or wants to kind of jump out in discussion, feel free to unmute yourselves. Otherwise, I will continue to blab at you. All right, I will continue to blab. So I don't know, it's tough, right? There's no real there's no like real great evidence-based guidelines on what you do with these cases.
I'll
But
ask something, Allie.
oh, great. Yeah.
Is this something you were talking about, the progestin IUD? Would this
Yeah.
be something that would be a better method of birth control instead of the LS for this type of
Yes.
situation? Okay.
Yes. Exactly. Exactly. She would be a great one for a progesterone only IUD. 100% agree. With an old stroke and a big PFO, I think if we could reduce the risk of venous clotting, that would be great. And I think that's kind of the main area where the main risk with the oral contraceptives is mostly venous clots, less likely arterial clots. Um, yeah, great. So that was kind of the piece around birth control that I discussed with her. And then what came up was that she was actually thinking about potentially getting pregnant in the next couple of years. So that also kind of threw a wrench into the whole situation and what we thought about what to do, considering that she was hoping to become pregnant and then she would be more hypercoagulable and would be delivering a baby with a big PFO and where to go with that. So um it's it's really tough. There's no evidence-based kind of guidelines or anything to direct us in Elise. Um, she's very young, but she's medically complicated. She also has significant arrhythmia. We haven't proven AFib yet, but she has of a lot of premature beats. So she's getting some longer term rhythm monitoring with cardiology, but they think that that might have caused this whole syncope thing in the first place. So that needs to get looked at. And she also is found to have elevated platelets, and hematology thinks she might have an essential thrombocytosis, so is monitoring that in her. So she's got like a few kind of moderate risk factors. What we've done for her right now is we've just anticoagulated her, knowing that she has this big PFO. She has like um, large amount of shunting with an atrial septal aneurysm, so high risk PFO. So we're going to kind of look at her heart and see what shakes out with the rhythm piece. And if we don't definitely prove that she has atrial fib, my thoughts were talking to her about potentially closing her PFO before becoming pregnant, just because I thought she would be at increased risk of venous thrombosis with a pregnancy on top of essential thrombocytosis. And I would be worried about her valsalvaing and bearing down in delivery when she's going to be kind of the most hypercoagulable, knowing she has a chronic stroke. We don't know when that got there with an open PFO, but if it was closed and we could prevent that shunting, I kind of thought that that made sense, but that is to be determined. Um, in her, I would avoid triptans personally, but I did give her some ubrogepant to try for her migraines. Okay, and then let's move on to pregnancy. How does pregnancy impact stroke risk? So the kind of really interesting thing as a stroke neurologist that happens in pregnancy is instead of this like, you know, general population, vast majority of stroke is ischemic stroke around 85% or something, and 15% is hemorrhagic. In pregnancy, it's not exactly this perfect 33% pie chart, but it's pretty close in terms of ischemic stroke, hemorrhagic stroke, and cerebrovenous sinus thrombosis. And then the risk increases significantly. So in pregnancy, a young woman's risk triples compared to her baseline risk of stroke. When in pregnancy are you going to be most worried, or might you most often see these women right before delivery and right after delivery, and then kind of for a longer, less acute time out to the first kind of 6 or so weeks postpartum is going to be the highest risk time, which makes sense, right? The body naturally has delivered a baby, has delivered a placenta, your body naturally wants to clot to prevent, hemorrhaging. But that's going to be the highest risk time for thrombosis, as well as a really high risk time for development of preeclampsia. And then just a quick slide to say that, in addition to normal risk factors in women who are getting pregnant, a lot of the amazing physiology and endocrine changes and cardiovascular changes that happen in pregnancy that the body needs to do to support the pregnancy and deliver a baby and keep baby and mom well are also risk factors for stroke. So just a slide to have on your in your files for those things. And then I just wanted to touch on hypertensive disorders of pregnancy, and for sure if there's primary care providers, maternity providers, obstetric people, you're going to know much more about this than I do. But I find that this is a bit of an under talked about topic in stroke and in neurology in general, but so interesting and so much kind of important and preventative work can go in here. So hypertensive disorders of pregnancy is this like, little great cluster of gestational hypertension, preeclampsia, eclampsia, and some of those things can be superimposed on chronic hypertension. And the main kind of timeline mark is that these hypertensive disorders of pregnancy should not start before 20 weeks. Anything before 20 weeks is going to be okay, newly diagnosed chronic hypertension, but anything after is more the pregnancy associated issues. And I think I have a case in here that will hit on that a little bit more, but we'll divert a bit with just a note to say, as a reminder, that our Canadian Stroke Best Practice Guidelines are excellent resources. We were working last year or the year before on updating the pregnancy guidelines. They're not out yet, but stay tuned. And just a reminder that if you are seeing or managing or hearing about over the phone, when you're giving advice, a pregnant woman with any acute onset disabling neurologic symptoms, we want to treat her as if she was not pregnant, meaning like if she's having symptoms that are maybe a stroke that she is not going to do well from or that are disabling, we want to image her acutely, transfer her to the right center, all of those things, because ultimately at the end of the day, we need healthy moms to have healthy babies. And if that means a CT scan and a CT angiogram, that's okay. And it's important to do to diagnose and treat people effectively. Why do we need to do this? Because we know that stroke in pregnancy is associated with poor long-term maternal health outcomes. This is a nice Canadian registry study. This paper was authored by Dr. Yu and colleagues, but looking at a group of women in Ontario that they followed out for almost 20 years. And what they found was that comparing pregnant people who had had a stroke in pregnancy to those who didn't, the number or percentage who ended up passing away or being readmitted to hospital for any reason within the follow-up period was significantly higher in the group who had stroke than who didn't, so almost 42% compared to 17%. And if we peek at that data as these kind of two lines on the graph there, we can see that the blue being the pregnant women without stroke and the red being the pregnant women with stroke. You can see that boom right away early on. Those lines are going to separate in terms of the probability of a poor outcome. So those curves divide early, but they continue to separate out for about the first 10 years before they kind of level off and continue to follow along their same slope. So just a little bit of a note to say that like that increased risk of having a stroke in pregnancy doesn't just go away after the stroke has happened. There's some different physiology, some change that is putting these women at ongoing increased risk compared to their counterparts who didn't have a stroke for a decade. Um, you know, whether that's because they're on anticoagulation now and that's a risk, or because of the vascular disease that caused a stroke in the first place, or potentially some alternate abilities, um, physically, mentally after a stroke. It's tough to know. What do we know? We do know that having even just preeclampsia in pregnancy increases the long-term stroke risk in a woman 3 times, which is huge. Um, so, and maybe kind of space or room for down the road us to talk about developing methods for screening or following these women and educating them and tracking their blood pressure and things like that, because we know that they're going to remain at increased risk for the rest of their lives. Okay, so looking at a quick case on pregnancy and stroke risk in women, this is one of my patients who I follow through our women's clinic, or did until she had her second child. But this is a 31-year-old woman who has some thalassemia trait, had episodic migraine but never aura, who 3 days postpartum from her first pregnancy with her son, she developed headache, and you're seeing her for that. So what happened with her pregnancy? Pregnancy was totally healthy, natural pregnancy. She was young, no medical problems, blood pressure totally normal. Um, Baby went into fetal distress in labor. Code pink was called. They found a nuchal cord with the emergency C-section. Baby was well, mom was well right after the cesarean section. She stayed in hospital for, I think, 3 days, 2 or 3 days, something like this, was healing okay, and they were discharged home. The day after discharge, she was attempting to nurse and kind of like leaning over baby, suddenly had 10 out of 10 worst headache of her life and returned to the emergency for that. In Emerge, her blood pressure was elevated. She was photosensitive, otherwise had a normal neurologic exam. Labs were normal. And this was her imaging, which shows this kind of these focal areas of stenosis of the anterior cerebral arteries bilaterally. In reality, unfortunately, the patient didn't get vascular imaging right away. She got a non-contrast CT head and was discharged home. And the blood pressure was felt to be related to pain, to like postpartum pain and headache. And I think she represented to a community hospital 3 or 4 times before getting vascular imaging, and then before stroke neurology was called. She ended up being transferred over to our stroke unit here at Vancouver General and treated as postpartum preeclampsia, with presentation of reversible cerebral vasoconstriction syndrome, or RCVS. She was put on calcium channel blockers. Initially, her imaging got quite a bit worse with quite severe vasospasm. She fortunately never had a true stroke. And then over the period of weeks, she was admitted to hospital as a new mom. The blood vessels did normalize over time. And then I got referred to her by one of my colleagues because she was considering having another pregnancy, and they wanted to know, okay, what can we do for her? What's the risk? What can we do for prevention? So maybe I'll just throw it out there to the group. If anyone wants to chime in, no stress if not, but would you allow someone like this to get pregnant again? Do you think there's any specific risks of the pregnancy itself? Anything we could modify? How about the delivery? What might you suggest? How about postpartum? Are there any medications or activity restrictions? Is there anything you can think of that we might want to do for her? Okay. Well,
Sorry,
I
would
was,
this be,
oh,
sorry,
yeah,
I was
go.
just going to say, would this be something you might think about maybe bed rest with blood pressure monitoring regularly?
Yeah, and you know what? I'm not smart enough about maternity care to know about bed rest, but 100% like activity restrictions, specifically kind of restricting Valsalva maneuvers, heavy weightlifting, intense exercise and things that can trigger that vasospasm. Um, and very careful blood pressure monitoring. Yep, we talked about getting a blood pressure cuff to have during the course of her pregnancy. And then aspirin. So aspirin for prevention of preeclampsia, which um, is what we thought had triggered this in the first place, a postpartum preeclampsia. So to try to prevent that from happening, I told her that, it was not up to me to tell her not to get pregnant. Was there a risk of this happening again? Yes. Could we say there's no risk? No. But are there things, kind of mitigating things we could do? Yes. So we did the blood pressure monitoring. We put her on aspirin. I sent her to an obstetrician locally, as well as to like an obstetric internal medicine service that we have here to help with the preeclampsia prevention piece. And they put her on some calcium supplementation and things like this, and talked more about activities. And then for delivery, I mean, in her, it made it a bit easy because she had had a very terrible time with the stress of the code pink. So she wanted to have a recurrent cesarean section. If she had really strongly wanted to do a vaginal delivery, what I would have suggested and have for other patients is to limit Valsalva. And generally, what that means, and I don't know if there's any obstetricians on the call or those who do deliveries, but what that generally means is in my note, I say, I'm worried about the patient Valsalvaing, bearing down kind of over and over again in labor. Can you help her with a type of delivery that would help prevent the need for that? And then what I've seen is that the obstetricians either talk to patients about cesarean delivery or an assisted vaginal delivery where they might use an epidural to help with pain management, and then do either forceps or vacuum or some sort of assisted delivery to get baby out, but then can still facilitate a vaginal delivery, but just minimize the amount of pushing. So that's what we did. She ended up delivering a beautiful baby girl. She's doing super well. Everyone's doing great, and had no reoccurrence of her postpartum preeclampsia or CPS. Okay. I'm sorry. I realize I've been blabbing slowly here, but let's maybe just pop through a little bit about menopause because I think it's a hot topic now, and I'm excited that it is. Um, So what do we know about menopause and stroke? Well, we know that, like we saw in that graph initially, the rates of stroke significantly go up in menopause and continue to double every decade postmenopause in women. And we also know that if the body is exposed to estrogen for too short of a period of time in life, so early menopause increases your stroke risk, but also a short reproductive lifespan, meaning the age you go through menopause minus the age that you've gone through menarche. If that's 30 years or less, that also is associated significantly with an increased risk of stroke. Thinking about this, we would think, okay, well, hormone replacement therapy, giving the body more estrogen, must be beneficial, right? And that's what, the Women's Health Initiative had thought when the original HRT trials were done decades ago now, was that these were going to be beneficial for heart and stroke. And then, unfortunately, that wasn't found. Now, overall, there's a little bit of, I think, shifting understanding and thoughts around safety of hormone replacement therapy and things, but kind of overall, what do the trials, what do the Women's Health Initiative trials tell us or show us? Well, they bring up the idea of the timing hypothesis that probably the higher risk time or situation to use hormone replacement therapy in is in women of older age, so over the age of 60, or those who have been more than a decade since they've gone through menopause. And I think physiologically that kind of makes sense, right? Because your body is going to have had that estrogen taken away. Those arteries that are used to being, a little bit more elastic, a little bit more vasodilated with systemic estrogen, now boom, are all of a sudden not going to have that. And women develop atherosclerotic disease fairly quickly. And then all of a sudden, if you've already had that change happen and then bring back estrogen, probably you're going to get, the bad clotting risk without the beneficial vascular protective risk. But what are some of the newer things that we might have learned in the decades since these studies? So there's good literature to suggest that vaginal estrogen is safe. So I would use this in women who are at risk of stroke, or in my women who have had stroke. I would say absolutely. If your symptoms are solved by vaginal estrogen, go for it. This is totally safe. And this is the reference from stroke. And then there's some literature to suggest that transdermal hormone replacement therapy is probably safer than oral options. Personally, if I have women who need hormone replacement therapy, I recommend that they go on the lowest dose of transdermal therapies as can manage their symptoms. There's some literature to suggest that the transdermal route of giving hormone replacement therapy bypasses the liver metabolism, which is where the procoagulable factors are produced. It's that kind of first pass metabolism. So if we can skip that, there seems to be a lower kind of thrombotic risk. But again, there's not big randomized controlled trials. But based on the literature that's available and kind of personal practice patterns, that is what I would suggest. And then there's some kind of cool new literature coming out about, what actually happens with these vasomotor hot flashes, sweats of menopause, and what happens to the brain. We had reviewed this publication recently in one of our resident journal clubs here in Vancouver that showed that followed women in menopause with serial MRIs and found that women who had frequent vasomotor symptoms, frequent hot flashes and sweats, accumulated more white matter hyperintensities on their MRIs than women who didn't have those things. So clearly something vascular is happening, but if that has impact on cognition, cognitive, reserve and things like that long term, hard to know. It was one small study, but I think interesting food for thought. And then just to kind of round off here, we'll just go through what happens and how vascular disease develops in peri-postmenopause. So starting with hypertension, dyslipidemia, and diabetes. So premenopause, as we talked about with estrogen exposure, women generally have low rates of these conditions compared to their male counterparts. But, crazy, postmenopause, 75% of the female American population will develop hypertension or be newly diagnosed with hypertension, with the majority of the blood pressure changes being seen in that first year post-menopause. We see similar things with cholesterol, again, a lot of new dyslipidemia, again, in that first year post-menopause. Even though we're seeing this, women are less likely to have their blood pressures and their cholesterol treated to target. They're less likely to be prescribed a statin. And if they're prescribed a statin, they're less likely to be treated to standardized targets as men are. And then there's some interesting new literature, mostly in the cardiology space, but I think it's going to kind of spill over into our realm as well soon. But looking at probably the effect of blood pressure on women and men is different. And we're seeing that a woman's stroke risk increases at a more moderate blood pressure, like a systolic blood pressure of around 120 millimeters of mercury, whereas in men, they can tolerate higher blood pressures before the stroke risk increases. And similar things are seen for diabetes as well, that lower glucose increases risk of stroke in women compared to men. So there's this kind of thought process around maybe we should have, gender informed risk stratification for primary prevention of these conditions because of what we're seeing more and more borne out in the literature, but we will see. And then just a quick note on ischemic heart disease. Women tend to have more anginal heart disease than men, but are less likely to have obstructive coronary artery disease and more microvascular disease. They tend to have a poor prognosis with their heart disease. Women's heart disease has been very, very helped in terms of diagnosis with the high sensitivity troponins. So that's a really, really positive move in the last number of years. And then just lastly about atrial fibrillation. Atrial fib, more women, slightly more have AFib because of the fact that women live longer, not because it's actually more common in females, but because women live to an older age, they're more likely to get it. But in women and men, atrial fib in women is associated with double the stroke risk than it is in men, which is super interesting. But women who have a stroke from AFib are less likely to be screened with telemetry, Holter monitors. And if atrial fibrillation is diagnosed in the era of like warfarin pre-DOACs, women were less likely to be anticoagulated than men for no real apparent reason. Now the data is equal in terms of people who are discharged on DOACs, men and women. And we'll skip that piece. All right, I think we should probably skip this last menopause case for time, but we can cycle back if you want to. So I guess all of this to say, talking about, female hormones and physiology, and then specific times in a woman's life that might be impacted by or might influence stroke risk. We know that although classically stroke's been seen as a disease of men, actually, if we look at the numbers, numerically more women have stroke, and there's a higher proportion of female deaths are attributed to stroke than men. What can we do to kind of change these stats? Women are more likely to have cerebrovascular disease misdiagnosed in the emergency department than men, or misdiagnosed by paramedics than men. Maybe thinking about it in women and asking about those sex-specific vascular risk factors like menopause, like did they have gestational diabetes, like did they have miscarriages. And then hopefully my dream would be to come up with some sort of population-based education program and screening to help treat and manage cardiovascular disease in women to prevent the development of stroke. All right, that is all I have for you. Are there any questions? This is me and my little guy in fellowship. I'm going to stop sharing. Okay.
Okay, so we have one question in the chat, and it said, what's your opinion on trying bioidentical HRT in someone with a history of migraine with aura that worsened with the estrogen patch?
And you would be using the bioidentical HRT to try to treat the migraine, or because they have menopausal symptoms?
I think
Migraine.
migraine.
Let's go with migraine.
Oh, menopausal.
Menopausal.
Opposite.
Yeah. Totally fair. I would probably have a risk discussion with the woman that like migraine with aura is a risk factor. And putting them on hormone replacement therapy is going to put them at some increased risk of stroke. If they really needed it, I would do the transdermal stuff. Vaginal if they only had local symptoms, otherwise transdermal. I would avoid oral. I would avoid oral hormone replacement therapy. Or if they could afford it, I would talk to them about like some of the treatments like Veoza and stuff like that, some of the non-hormonal menopausal management treatments.
Thank you. Does anyone else have any questions? I was reading an article this morning to prepare for this, and I forgot to bring it, of course, because I highlighted it. But I found it interesting that it talks how estrogen can be protective for women. But then sometimes when you're taking estrogen, it's not like it doesn't protect you. The exogenous estrogen doesn't really seem to be protective.
Yeah, and it seems to be like dose related, for sure. And then exogenous totally versus like what is made naturally in the body versus kind of what you add on top.
Yeah.
Um, and I think kind of overall the literature looks like, long-term exposure to like low endogenous levels is good for vascular health, for blood pressure management, for insulin um, reactivity and things like that. But like whopping on a bunch of exogenous estrogen, you're going to probably get the like procoagulable
Hmm.
risk. So you're going to get
Hmm.
the venous thrombosis and arterial thrombosis, um, kind of negative effects. So finding the balance, I think, is the main thing. What is the difference in the blood
Between
glucose levels between risk? You know what? I don't remember off the top of my head like where the change happens. But I can send the paper if you like. But yeah, at a lower fasting glucose, a woman's stroke risk is going to increase compared to a man's.
not fair.
Honestly,
No.
honestly.
Okay.
All
Hi,
right,
I
should we
just had a
say?
question. Sorry. I'm Sarah from former Kelsey Trail. I just had a question about the protective effects of cardiovascular exercise. Then once women do are postmenopausal and then their risks shoot up, like is there much preventative factor from cardiovascular exercise?
Yeah, 100%. A really good point. I should add that in. Cardiovascular exercise or like aerobic exercise, to help mitigate some of the like hypertension, cholesterol, diabetes stuff development in that perimenopausal period. But then also, evidence would suggest weight-bearing exercise in that population as well, because of like the bone thinning osteoporosis, all this like nice stuff that we have to look forward to, but would also be evidence-based, but 100% continuing with like a well-developed aerobic exercise plan is very protective in this population.
Okay. Well, that is our time, and I know you are on call. Hopefully not for too much longer.
2 more
But thank
hours.
you. Oh, you can do it. Well, thank you so much we were so excited to have you. So thank you for taking time out of your busy schedule to do this. And we'll email so that you can send me some of these resources that I'll put in our newsletter. And then as always, I'll post this to YouTube so everyone can rewatch it. Anyone that's missed it, I see some thank yous coming in. If you guys do want to turn on your cameras so she can see everyone that attended, that'd be lovely. It's always much appreciated. And then just a reminder, we did extend the deadline for our Saskatchewan Stroke Awareness Day. So June 17th, we're going to have, you can do a stroke booth. It can be anything you would like. You can do wellness checks. You can provide information. You can just talk about signs and symptoms of stroke. So I'm going to send out an email about that. Effie from Heart and Stroke, I'll put her email in the newsletter, and you can email her if you'd like a package sent out with some swag and some resources to hand out to the public. And I think that is it. Do you have anything else to add?
No, that was amazing.
That
I think
was-
you hit on like a lot of the high topics
Yeah.
that we're often hearing about in clinic and just kind of out there in the general public with questions. But just identifying still like individual treatment based on data that we have for the population, but really honing in on females being treated different than males and how that affects your individual patient. So thank you so much.
Yes.
No worries. Thanks, guys. Have a great
Okay.
afternoon.
Thank you. You too.
Bye.
Bye.